So I am going to go ahead and get started presenting on mental health, ADHD, and how it relates to nutrition. So I do have our learning outcomes here that you can go ahead and take a look at later, and our key points that we'll be addressing in today's presentation. So first, I'd like to start with the definition of ADHD. It is attention deficit hyperactivity disorder, and it is characterized by difficulty in delaying gratification, inattentiveness, distractibility, impulsive behavior, anxiety, excessive motor activity, and you can also see some emotional immaturity, aggressiveness, and poor academic performance. So to diagnose ADHD, the two things I've found from my research is the symptoms have to interfere with functioning and be present in two or more settings. So for example, if you have a kid that you are concerned about having ADHD, you would want those symptoms to be present at school and at home before you made that diagnosis. Also, the American Psychiatric Association requires at least 6 symptoms of inattention or hyperactivity/impulsivity for diagnosis of ADHD. Most physicians, before they will give an individual this diagnosis, would like to have seen the symptoms last at least 6 months before they would give that actual diagnosis of ADHD. Also, there are some published guidelines from the American Academy of Pediatrics. Recommendations are about diagnosis and treatment as well. So we do see this to be diagnosed 2 to 3 times more in boys than girls. The average age of diagnosis is 6 to 7 years. And the reason why you see that average age at 6 or 7 is mostly because that is when a child will start school. And like I mentioned before, you would want to see the symptoms in 2 or more places, like home and school. And then siblings of an individual with ADHD are at an increased risk for diagnosis. So the main reason why I was asked to present on this is there's a lot of concern about diet and nutrition and if it actually causes ADHD. So ADHD is a complex etiology, and it really boils down to being both from genetic and environmental factors. In 2 articles, I saw it listed as a neurobehavioral or a neurodevelopmental disorders. There is no actual proven link between the diagnosis of ADHD with a diet or nutrition problem. However, today I will talk about how the current diet may affect symptoms and how vitamin supplementation can alleviate some of those symptoms, and how studies have shown elimination diets can actually help with ADHD symptoms. So to confirm this slide, it's really ADHD and symptoms that are linked, not necessarily an actual diagnosis or problem from diet or nutrition. So some of the main things that were studied between nutrition and ADHD were ADHD and dairy intolerance. So there's no association. Several articles trying to link celiac disease or gluten intake, and no evidence supports that at this time either. There was a lot about short-term sugar consumption. So this is, I thought, that was something kind of unique how they worded it and how the study was. So short-term sugar consumption is not necessarily associated with ADHD. And they really described this as a relationship between sugar and hyperactivity that might worry parents or teachers. And really what they found is that the sugar and the hyperactivity could be influenced by environmental or situational factors. So one example they said is if you had 10 children at a birthday party, and of course you have punch and birthday cake, and there's a whole bunch of extra hyperactivity, that situation, yes, might cause a child to be a little bit more active than in a setting where there was sugar intake and no friends around to run around with. So really, After the controlled trials of sugar restriction diets, they found that sugar has no effect on behavioral symptoms as a long term. So I did want to look to see if there was any diagnostic testing for ADHD. And so we do not have labs that actually can be used by physicians to diagnose ADHD. However, there is a lot of things that we saw in common in the studies between deficiencies. So there was low levels of iron, hemoglobin, zinc, magnesium, vitamin D, and B vitamins found in children that were diagnosed with ADHD. So this is something that should be addressed as far as vitamin supplementation. And sometimes with the vitamin supplementation, with the studies, there was decreased symptoms due to that supplementation. Also, one that was a huge deficiency and lab was lower serum levels of omega-3 and omega-6. So this could be caused by poor absorption or increased metabolism of the polyunsaturated fatty acids. So that one was more significantly linked with ADHD patients as well. So a very, very common thing that was linked a lot between ADHD and diagnosis and symptoms, or excuse me, not diagnosis, between ADHD patients and symptoms. There was a lot of concern and articles linking possible concern about food additives or dyes, and if this was causing the symptoms and then leading to that diagnosis of ADHD. So food additives have been used for years by manufacturers to enhance natural colors, or they're used to make, things look more appealing, for instance, like vegetables and flavors and things like that. So these were actually introduced in the 1970s. And so flavors, preservatives have been around for a long time. There's particular concern about artificial colors and dyes in regards to the red and yellow. So there was a lot of studies about elimination diets of the red and the yellow dyes. However, they did find those to be inconsistent, and they do not think it causes that ADHD. But like I mentioned, when eliminated, it can diminish some children's symptoms. Another thing that was found was iron deficiency. Iodine deficiency has been linked for an increased risk of ADHD. So iodine is going to be found mostly in multivitamins. A lot of countries already supplement this in their food. You can have iodized salt to correct that deficiency, or you can find that in the saltwater fish, the seafood, and some dairy products. So iodine deficiency did confirm a link between increased risk for that diagnosis. And like I mentioned before, with the lab values, omega-3 and omega-6, so salmon is rich in those products and vitamins, so getting some support for brain health that way. Also, high protein diet, having foods that are rich in protein are important because this is already linked to better performance in school in children that don't have ADHD. However, it can help concentration and help medications last longer for children that have been diagnosed and also are on medications. There really is a lot of information also about, continuing to encourage complex carbs versus simple carbs, having those carbs for energy, and then processed foods. So I do think some of my takeaways from the research with the sugar and the elimination diets for sugar was really linked to processed foods. And so making sure our kids are not getting processed foods as much to help eliminate some of those ADHD symptoms was really the takeaway from those articles. So elimination diets is by definition, stopping consuming foods or ingredients that can be triggering to symptoms or make symptoms worse. So this is something that is individual based. And so as a parent or a teacher, when they notice those ADHD symptoms, those sometimes have to be written down and decided by the parent if they want to decide to eliminate certain foods at certain times. And this might be a trial and error thing, making sure we're looking at the actions and the foods and if those are linked. Also, avoiding caffeine. Caffeine has been known to cause anxiety and affect the ability to sleep, but it can also cause some stomach issues. And the main thing with ADHD and nutrition is caffeine. Caffeine is already a stimulant, and most of the medications that treat ADHD symptoms do contain stimulants. So it is recommended to avoid caffeine as much as possible. Iron and zinc deficiencies can increase the symptoms. So this is one where there was a proof between iron and zinc deficiencies and reduction of symptoms when those labs have been drawn on those kids. And when those were deficient, we did see a huge reduction in symptoms with supplementation. Specifically, they have tied the omega-3 fatty acid to lower impulsiveness symptoms. That could be like excessive touching, excessive movement, not being able to stop and those movements before thinking. And then the huge one that I thought was very interesting, because I had seen this in some outpatients in the past with ADHD. There is a lot of studies that show low levels of the vitamin D in children that are newly diagnosed with ADHD. And the vitamin D deficiency was linked to some supplementation when taking the methylphenidate. So if you have decreased hyperactivity and attention and decreased behaviors shown with that vitamin D supplementation, if that kid is also taking the methylphenidate. So there is a big link between that particular ADHD medication and vitamin D supplementation needed. So I'm not going to hit a lot on the treatment just because Andrea is going to talk about the medications with ADHD, but just a general overview with the treatment plan. The first thing that we do like to see as a treatment with ADHD patients is parent training and behavioral management. Because that diagnosis is usually at age 6 or 7, there is going to be a huge parent involvement and also teacher involvement. So sometimes teachers already have that training in behavioral management, and we just need to let the parents know some better tactics. So there is approved therapists to work with them. Also, behavioral classroom interventions. Most schools now have specific plans to help with ADHD or any learning disability. There's lots of options for a specific plan between the teacher and the parent and the child. And then there are several FDA approved medications. I did find, and I guess Andrea can confirm or deny this, but from my research between the nutrition and ADHD, most of the children were started on the methylphenidate as the first line of medications. And that is why I focused a little bit on those nutrition interactions with that particular medication, like the vitamin D deficiency. So one thing I thought that was very, very interesting and kind of different was there was a prevalence with ADHD in children that had allergic rhinitis. So there has been studies showing that if you can treat that allergic rhinitis, that can decrease ADHD diagnosis and actually symptoms in children. So there wasn't a ton of studies about this, but it was a newer study. And so with that, I thought, that's definitely something I hadn't heard in my career yet. So interesting. So as how this relates to a dietitian and a treatment with nutrition and ADHD, the stimulant medications can cause appetite suppression. So there is medications that will, like I said, have stimulants, and those stimulants cause that appetite suppression. And so there is links between the medications and the appetite to cause growth delays and lower BMI in children. So doctors will have med checks with the ADHD patients to make sure they're gaining weight appropriately. And if they are not, then that is maybe when a dietitian would get a referral to help a child gain some weight. Or maybe it would be focusing on eating things that are high calorie, high protein, depending on what that individual child is taking. Most of these medications are taken in the morning, and so that does cause a lot of children to skip lunch. From what I have seen from the research and also the few outpatients that I had seen in my career, you do want to make sure that the child is eating breakfast before taking the medication. The medication can suppress that appetite pretty quickly. Also, typically these children will skip lunch and probably not be hungry until 2 or 3 in the afternoon. And so making sure that they have a healthy snack after school sent with them if they're going to daycare. There might be a need to communicate to like an after school program as a parent or a teacher about this particular child having more protein or calories than a normal just after school snack. So making sure that the meals and snacks can align with when the child will be hungry, and also to make sure we're still getting all those nutrients from the food groups and meeting that child's needs to kind of prevent the growth delays and lower BMI. Unfortunately, with the stimulant medication causing some suppression with the appetite, there is a risk for impulsive or overeating when the medications wear off. So there has been some studies that there is children that will eat in the middle of the night because they are super hungry. And this can cause some disordered eating, and the fact that they can be so hungry that maybe they just grab a bunch of junk food versus, a nice meal with protein and fruits and vegetables. Also, if a child is getting up in the middle of the night and eating, a parent might not be able to supervise what their actual diet and nutrition intake is. So a lot of the recommendations are to have specific meals set aside for that child to eat in the middle of the night, foods that they know are good for them to grab and go, and then foods maybe that the parents talk about, like, hey, let's try not to eat these things if we're going to get up in the middle of the night or eat later on. The one study that I saw between the link between the vitamin D and the ADHD and the need for the supplementation was that it also was linked to the lower bone density. Stimulants actually lead to a decrease of that bone accrual, and that can lead to the increase of risk and fractures. Also at med checks, there is a need to make sure there is that vitamin D supplementation meeting the needs of that child, because we do see excessive and increased fractures in that ADHD diagnosis. So kind of in summary today of my portion, the nutrition and the diet will not cause ADHD, but there is a ton of research supporting elimination diets, helping those children alleviate some symptoms. So as a dietitian, it is very important that we are working with the ADHD patient and their parents and their teachers to make sure we're getting an accurate food intake and seeing some tracking between the symptoms and the foods. Also, supplementation may help with those nutritional deficiencies, but really there's going to be some supplementation that should really be required, especially with certain medications like the vitamin D. And then also, like I said, the weight monitoring is recommended with any medication use with a patient with ADHD. So we'll just stop here to see if anybody has some quick questions about my portion before we switch over to Andrea.
Thank you, Deborah. We do have a few questions in the chat. One of them is there a certain amount of added sugar in foods that we should avoid with kids?
Yeah, so the research really showed all added sugars or processed food should be avoided. So utilizing that label, that is the nice thing that got added to the nutrition facts label on the back of products, is we have the added sugars column that is showing us if a product is processed or not. So all the research I read was anything that is a processed added sugar product really should be avoided. There wasn't a direct link that, said this sugar causes ADHD, like I said in my slide, but the processed food did seem to increase those symptoms. So really getting back to the whole, fresh, clean foods.
Thank you so much for that. The next question is, what is the recommended dose of vitamin D supplementation for kids on methylphenidate? Is the dosage age and or weight based?
That's a great question. So I do not know specifically the number of milligrams, that I use of vitamin D that would be required when you're on the medication. Now, vitamin D supplementation is recommended for women and boys differently, with the sexes. And so it is based on age and gender usually. I don't necessarily have seen the vitamin D on the weight-based. So, and Andrea is confirming she hasn't seen that either. So I can try to look that up a little bit more and see if there is an actual recommendation. But in the research I read in the articles, it did not give a specific amount. It just said it was very necessary with that medication. So that's a great question. I will definitely look that up.
Thank you. And another question we have is there a kid's supplement for omega-3s, or is it a fish oil like for adults?
Yeah, so, the omega-3s can be found in salmon. So obviously a kid can eat salmon. I would, of course, try to incorporate food for supplementation as much as possible first. And so that is where you're going to get the better absorption. But those supplement pills can be taken by children as well. I just don't know how well a child could swallow some of those fish oil supplements because they can be pretty big. So I would definitely recommend trying to do the salmon and some of the food products that would contain that before I would start with the pills.
Okay, thank you. And we do have one more question. Not sure if it's going to be for you or for the next speaker, but because of the impulsive eating, is that why some providers prescribe Vyvanse? And I might not be saying that correctly.
So it's Vyvanse.
Vyvanse. Okay, thank you.
Yeah. So I mean, Vyvanse has a longer duration of action. It lasts about 12 hours. But really, it just kind of depends on what they've tried. And each patient is individualized on what works for them. And actually, in my talk, I'll get to Vyvanse. That is really on a nationwide shortage. So patients are having difficulty finding Vyvanse right now.
Really? Very interesting.
All right, thank you. That's all the questions we have so far.
Like Deborah said, I'm going to focus on the medications for ADHD. And to be quite honest, I have been a pharmacist for 20 years and have only ever really worked inpatient. So this was a good refresher for me to look at all of this again, because we don't really see this on a inpatient basis for patients that are in the hospital. So the objectives, I'm just going to kind of talk about the pathophysiology with ADHD and how the medications can kind of help with that. The ADHD medications, drug interactions, and then guideline recommendations. Oh, like Deborah said, I'm not really going to read this slide, but ADHD usually manifests in the childhood with those symptoms. The symptoms usually are present when they start school because you see it in the academic, behavioral, emotional, and the social functioning with friends and classmates at school. So here's kind of a slide of the pathophysiology. It's a genetic imbalance of dopamine, epinephrine, and norepinephrine metabolism in the cerebral cortex. Dopamine may be cleared from synapses too quickly in ADHD patients per animal models. So that's why it's thought with medications that can be improved. So ADHD medications such as methylphenidate work to increase the extracellular dopamine in the brain to compensate for elevated dopamine clearance. So in the picture, it demonstrates the mechanism of action of methylphenidate and its ability to inhibit reuptake of dopamine and norepinephrine, thus increasing these transmitters in the brain. So kind of too, though, you can have, like Deborah said, you can also have the environmental factors, which are somewhat controversial with like the diet, sleep deficiency, taking prenatal vitamins, prematurity. So the mom taking prenatal vitamins. And then you have other comorbidities with behavioral emotional conditions such as anxiety, depressions, or substance use disorders. So obviously with any treatment, you want to rate the benefit and the risk. So the treatment goal is always to reduce the core symptoms of ADHD, improve their overall functionality, like in school and everyday life. And then the goals of the medications are to alleviate those symptoms throughout the day so that they can function in school, social situations, and their activities. So kind of the timeline for medications. So back in 1941, there was studies that showed that amphetamine was beneficial to children with behavioral disorders. In 1967, methylphenidate was indicated for the treatment of behavioral disorders in children. Amphetamines were clinically used in 1937, though, to replace epinephrine, and they were more widely used as bronchodilators, which subsequently led to the recognition of its possible implications to treat other conditions such as headache, motivation, and then even behavioral disorders in children. Then in the 2000s, that's when we saw the development of long-acting stimulants such as Concerta. And then between 2000 and 2010 is when we had the other agents such as atomoxetine and the alpha adrenergic medications that we use in ADHD. So I'm just kind of going to go through the classes of medications that are approved for medications for ADHD. So we have stimulants, we have amphetamines that are short and long acting, we have methylphenidates that are short, intermediate, and long acting, and then we have the non-stimulants such as atomoxetine and the alpha-2 agonists, clonidine and guanfacine. So I really could have probably spent an hour alone on medications and how to dose and how to convert from the different formulations. So this is just really a quick guide of the long acting, short acting, and then the non-stimulants. So the extended release tablets, the biggest thing you want to make sure you do is to not crush it. You cannot crush extended release tablets such as the Focalin XR, but you can sprinkle it. The Concerta tablet, it is not a extended release tablet, but it has a unique drug releasing mechanism. So if you crushed it and combined it with water, it would form a gel. So not really too conducive to having a child take it if it's in a gel-like form. The Daytrana, which is the transdermal patch, that you usually start at 10 milligrams once a day. You apply it to your hip 2 hours before the effect is needed, and you remove it 9 hours after application. but you would want to at least do it 3 hours before bedtime so that the child can sleep or the patient can sleep. Then we have our short-acting stimulants, our methylphenidates. So Ritalin, Focalin, and Methylin. Those all, as you can see, all have a shorter duration of action. Methylphenidate, like Deborah said, is recommended as the first-line therapy for children and adolescents, and doses should be individualized to the patient. Then we are going to go into our stimulants, our long and short-acting amphetamines. So here we have what you've all probably heard of Adderall, Vyvanse, Dextrostat, and you can see their durations of action as from the slide as well. With these medications, and kind of too, if you work in retail at Walgreens, CVS, these medications are all kind of dependent on brand and generic on what your insurance coverage is. Your insurance could determine what brand versus generic that you can have filled for your child. Adderall is usually the most affordable stimulant right now. Vyvanse does have is available in a capsule or a chewable tablet. And usually those are the most common ones that we have seen. So kind of to wrap things up with the stimulant class. So this is a Schedule II medication. So what that means is when you go to your provider, you will only get a month prescription for that medication. There's no refills on it when they write for it. It must be filled from 6 months from the day that the prescription was written. The administration of it, since they are usually the controlled release and extended release tablets or capsules, they should be taken in the morning. And they usually have them take them before the child goes to school. And then the immediate release tablets or capsules are to be taken as scheduled or as needed, depending on the child's symptoms, but not close to bedtime. You can take them with or without food, but always take it with a full glass of water. Adverse effects. So dextromethylphenidate may have fewer side effects than the methylphenidate. Their common ones, like Deborah said, are insomnia, decreased appetite, mild increase in heart rate and blood pressure, which makes sense because it is a stimulant, weight loss, headache, nausea. The rare ones are behavior rebound, psychosis, anxiety, or depression, but it is a possibility. For monitoring, you always want to, because they are stimulants, and if you crush it, they work a little differently. You always want to monitor for abuse or misuse, sleep and behavioral changes with the child or patient, monitor their weight, like Deborah said, making sure they're eating a well-balanced diet. They can have their blood pressure and heart rate checked at every appointment. And then two, if they're going to be on it for an extended period of time, they will always do lab checks and check their complete blood count as well. So kind of like I already said with the Vyvanse and the nationwide shortage. So there is a nationwide shortage with Adderall IR, XR, Concerta, Vyvanse, and there really is no update as to when that shortage will resolve. The shortage is happening because the DEA has put limitations on the manufacturers for how much they can manufacture. So the DEA believes that their limitations, the limitations that they have set, that should be enough for the manufacturers to supply to pharmacies. So we will see, actually, like in February, CBS, ABC, NBC all did national stories on this because of the shortage, because it has led to frustration with patients and their parents, because you pretty much have to shop around to pharmacies and call them to see if they have your medication in stock. And so then you have to call your doctor and then tell them where to send that prescription. And I don't work in our retail pharmacy often, but I do know that we have about 10 patients that come from Omaha to Fremont to get their prescription filled for their ADHD because we have it in supply. So then to our non-stimulants. So this is atomoxetine, which the other name is Strattera. So its mechanism of action is it's a selective norepinephrine reuptake inhibitor. So some of the things, the pearls with atomoxetine is it does have a black box warning. That's what BBW stands for suicidal thoughts. So you want to closely monitor the patient early in therapy to see if they're having any suicidal ideations or thoughts. It's reserved for patients with a history of substance use disorder or cannot tolerate or have a sufficient response to the preferred agents. It usually takes 2 to 4 weeks before you see any effect. And the max dose is 100 milligrams per day. Clonidine, this is our alpha-2 antagonist. Its biggest side effect that you can see is sedation, like dry mouth. It's used as monotherapy or as an adjunct to stimulant therapy. This may be optimal for patients with tics or Tourette syndrome or have a history of psychosis. The biggest thing with this medication, though, is you have to taper the dose. You cannot just stop it abruptly. So you have to discontinue it over 1 to 2 weeks. The max dose is dependent on the weight of the patient, so it can range from 0.2 milligrams per day to 0.4 milligrams per day. Then for guanfacine, this is not typically used as a first-line agent. It's suggested for patients that are intolerant or have a lack of response to stimulants. And an adequate trial of at least 6 weeks with stimulants is suggested before you start the guanfacine. Dosing with this medication is different for patients with ADHD. And then if you have a patient that has autism spectrum disorder, ADHD. So there's different max doses too, depending on the age of your patient. So 6 to 12 years old have a max dose of 4 milligrams per day. 13 to 17-year-olds have a max dose of 7 milligrams per day. And then if they're on a psychostimulant, then the max dose is 4 milligrams per day. And the biggest side effect that people see with this is irritability. So now on to interactions with other medications. So some classes of other medications. So monoamine oxidase inhibitors. This is a big one, but I don't know if children would be on these medications. So it can cause a hypertensive crisis, heart attack, stroke. You want to stop the monoamine oxidase inhibitor 14 days before you would start anything to avoid the interaction. Sudafed, children could take this. So like because Sudafed is also like a stimulant, it could have an increased risk for cardiovascular side effects, elevated blood pressure, elevated heart rate. So you just want to monitor for symptoms. Kratom, which is what you can get at gas stations now. It's over the counter. This has an increasing stimulant effect too. It can elevate blood pressure, heart rate, has a seizure risk if they are used together with the medications. Like Deborah already mentioned, caffeine, because it is a stimulant, can also lead to more being nervous, irritable, insomnia, tremor. So like Deborah already mentioned, you should reduce or limit the caffeine intake of your patient. And then hopefully children are not consuming alcohol, but when they are teenagers, you might see this. So it can also lead to trouble sleeping, anxiety, and increased heart rate. So adults too with ADHD should limit alcohol to 1 or 2 drinks, even after duration of their therapeutic effect of medications, so that they avoid these adverse reactions with the medications. So I don't know if you can see this diagram, but this is from the American Academy of Pediatrics. And this just shows how complex it is to treat a child with ADHD and all the steps that you have to go through. And it's a collaborative decision between the parents, the provider, school so that the child can function to the best of their ability while they're in school. And I know some parents decide to not have their children take the medication when they're not in school, and they only take it when they're in school so that they can function better in school. So here are the therapy recommendations. So preschool, gosh, that seems young to start a child on medications, but it's up to the parent, teacher, the provider. And in preschool kids, you can start methylphenidate to help with the behavioral disturbance that if they are having in preschool. Elementary school age, so 6 to 11 years of age, this is where the diagram before, you want an evidence-based parent-teacher administered behavioral therapy, and then an FDA-approved medication. So you're probably going to see the methylphenidate, Ritalin as your first line. And then 12 to 18 years of age, once again, you're going to have the cognitive behavior therapy and then an approved medication, with making sure the child understands when they're supposed to take it. And then adults, usually, so greater than 18 years of age, you have the cognitive behavioral therapy plus amphetamines. Any questions?
Thank you so much for that, Andrea. We do have a question. If on a non-stimulating drug, could Sudafed counteract that?
On the non-stimulant, no.
Okay. Another question. I have heard anecdotal evidence that caffeine can have the opposite effect on people with ADHD. Is this only in people with ADHD who are unmedicated? Any research on that, or just anecdotal?
I have not heard that, so I would say that would be anecdotal, because I mean, caffeine is a stimulant, so you're always going to have like anxiousness if you're consuming a lot.
Okay, thank you. There's no other questions right now.
So I just wanted to kind of address the question earlier. I was able to find a study with the vitamin D supplementation that was directly linked between ADHD patients and then the drug, the methylphenidate. So they did recommend no more than 2,000 IUs of vitamin D supplementation for children that are age 4 and above. For a year or less, the recommendation was only 1,000 of IU of vitamin D, but I don't think we're going to see ADHD symptoms in a child that's a year or below. And so really, this study was 62 kiddos, ages 5 to 12. They did the 2,000 IUs of the vitamin D supplementation. And what I'm seeing from the couple studies that I did find, they really want to have that supplementation at least 8 weeks, if not 12 weeks, before they would see that symptom reduction or the benefits from that supplementation.
Thank you so much for looking that up so quickly for us. We do have a question. If you could share the link to that study, are you able to share that in the chat for everybody?
For the vitamin D?
I think that's what they're referring to, yes.
Yeah.
Yes.
Absolutely.
Okay, that'd be great. Thank you.
And just to like kind of summarize too, I found this morning that 6 million children in the United States are diagnosed with ADHD, and approximately 8 million adults in the United States. So this is a huge patient population.
Mm-hmm. Yeah, I have seen quite a few outpatients in my career field, and then, or in my career as an outpatient dietitian, and then also the personal experience with a nephew that's currently 6 and a nephew that's currently 15. And both of them do take the methylphenidate, and both of them have the disordered eating when it wears off. And also both of them have had severe GI symptoms because of the medications and the overeating in the evening. So that's something they're trying to work on. But my nephew that's 15, he has actually had several fractures that were non-contact. And so he did have a vitamin D deficiency, and he did have to increase his vitamin supplementation because we did see that relation between the medication and the fractures. So it was nice to see research that kind of confirmed what I've seen with outpatients or my nephews, just to understand how this nutrition and medications do require that supplementation of certain vitamins, and how the symptoms do line up with the diet and the intake. So I think seeing that in both of our careers, me and Andrea were able to see those relations between the importance of understanding the medications and how that can affect a child with ADHD.
Thank you for that. We do have another question that came in. Is there an explanation for the increase in the diagnosis? Is it from doctors recognizing it and maybe knowing more about it, parents advocating, or a change in our diet and environments?
I don't know if we ever know for sure why there's an increase in any diagnosis. We have an epidemic with diabetes diagnoses and things like that. So I think really there can be several reasons why we see the increase. I do think that the behavior training that is given to teachers and the behavior training that is available to parents, could also just catch those things a little bit sooner than in the past. I think we have tried to educate our teachers to see these responses in children. And then I think as I would say, as the research evolves, you would, I think, see the doctors recommend medications in certain situations.
I think it also would be interesting to see like how we are so technology driven now as a society. And I mean, you see pretty much kiddos when they're 2 and 3 on iPads and tablets already. So I don't know if there's studies going on, but if there is a link between just the stimulus with the screen time and how that is changing the evolution too of diagnosing it or the behaviors of our children, because there is a lot of kids that are on their screens all day.
And I would say, as far as the asking for the change in our diet and our environments, I think, the USDA and FDA have worked on increasing the amount of nutrition information that is provided on a product. For instance, like the question about the added sugars, there isn't a direct link between that sugar intake and diagnosis of ADHD, but there is a link between the processed foods and the unhealthy diets, because there is deficiencies. If you're not going to be eating fruits and vegetables and proteins, you're not going to meet your vitamins, you're not going to meet your iron, your zinc, if you're not eating things that contain those. So if you are having the products that are processed and the added sugars, so I think, in the response to that, we have increased the nutrition value information that is on the labels. So parents can look at a product and say, oh, well, there's 26 grams of added sugar in this. There's no potassium, there's no calcium, there's no vitamin D. Let's avoid this. So great questions. Great questions.
Mm-hmm.
Are there any more questions? We do have a comment. Really good dialogue on diagnosis and increase or decrease in certain environmental factors in diet.
Yeah, I think if anything, obviously the huge takeaway from this is we have to be proactive and utilize any of our resources. So as dietitians and pharmacists, any kind of education we can give to that patient or teacher or child to help themselves is obviously a huge role of the dietitian and the pharmacist. And I guess I personally witnessed some nutrition questions when I was picking up my prescription here at Fremont one day. One of the patients in front of me had a question about fiber, and the pharmacist was able to answer that. So I do think you as a pharmacist, get a lot of nutrition questions. And as a dietitian, you can see how medications can affect the nutrition in a patient. So I think it is great to be able to have this presentation about how this particular disease, I don't want to say disease, but this particular diagnosis of ADHD really does encompass working together.
Absolutely. We do have a comment. Thanks, ladies. Such good info. And another question. As a nutritionist, is there a vitamin brand that you recommend for kids to help supplement with diet?
So that is a very common question. There isn't necessarily FDA approved vitamins, like there's FDA approved medications. So I find reputable vitamin brands to be like the Spring Valley or the Hy-Vee brand. The biggest thing with vitamins is you really don't want to go over that 100% recommendation. There's recommended daily allowances for a reason. So you can get too much of a good thing. So you want to make sure that you're not buying a product that has 1,000% of something. So not necessarily a brand, but look at that label. Andrea, do you know any brands that you sell at the pharmacy that are?
I can see the labeling, but I don't know the brand. And I know that they're gummies, which is kind of I don't know what's the word I'm looking for, because they taste like candy. So you don't necessarily like you want to make sure that those aren't just readily available for your children and that you're giving them to your child, because they do taste like candy. So they could be mistaken for a gummy bear or fruit snacks. But I know that they're the easiest to have children take, but I can't think of, let me look.
Yeah, I do think that's a great point, Andrea, about making sure there's the safety involved, because some of the vitamins now are gummy and also really appealing to children. I actually have recommended to outpatients the Flintstones chewable vitamin. I actually recommend the Flintstones chewable vitamin to children and adults, because if you look at the percentages in the Flintstone vitamin, they can meet a lot of those percentages for adults and children, and it's pretty affordable. So there is some of the vitamins that will have the USP listed on there instead of FDA approved. So you can go ahead and do that. And then, oh, yeah, Andrea found it. It's Nature Made. So yeah, Spring Valley or like Nature Made is a reputable brand. And then, like I said, your store ones like Hy-Vee or Equate are going to be okay. But look at those percentages and don't buy things from different countries. That can be tricky and unsafe.
We have a comment here from somebody that has personally tried Renzo's with their 6 and 7-year-old. They say that it tastes good and it's great for picky eaters. What are your thoughts on that?
I have never heard of Renzo's.
Let me look at Renzo's vitamins. Yeah, I've never even actually seen that.
Yeah, me and Andrea have not seen that particular product, but I would say, yeah, if it's meeting those percentages and not going over, I think that would be an okay product.
Yeah, it looks like they have one specifically for picky eaters. So it must have the daily allowance of what you're supposed to get vitamin intake wise.
Okay, I don't think we have any more questions.
Well, thank you for everybody that joined today. There was great participation. That is so awesome to see the support for the dietitian and pharmacy world.
Absolutely. We do have another comment. This was very helpful and informative. Thank you so much.
Absolutely.
Yeah, thank you.
Okay, I think that will do it for this program. Thank you both so much for sharing your knowledge, your insight, your perspective. We truly appreciate it.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.